So should we start, ma'am?
Yes, please.
Okay, so very good evening to all respected delegates members and the faculty members who are present over here. I am Nilesh Darji from Corona Remedies. Welcomes you all in this 21st edition of Searchlight in association with Bijapur, Firozpur, Karnal, Karad, Kotakpur, Kottayam, Kohima, Krishnagiri, Lucknow, and Bhimavaram Ops and Gyne Society. And the topic for today's webinar is primary amenorrhea. So that was about the webinar. Our first conveyor for today's webinar is Dr. Sujayashree Sangeeta. So let me introduce Madam. Currently, Madam is appointed as consultant obstetrician and laparoscopic surgeon at Seshadri Hospital, Palakot, and Seshadri Hospital, Malkipuram. Madam is founder secretary Bhimavaram Obstetric Gyne Society and also secretary at IMA Palakot. And Madam has also received various awards like Shan S. Ratnam Young Gynecologist Award and Foxy Dhira Award. Madam's fields of interest are laparoscopy and infertility. So we welcome Madam Dr. Sujayashree Sangeeta ma'am. Our co-convener for today's webinar is Dr. Aarti Sridhara. So Madam is currently consultant obstetrician and laparoscopic gynecologist, medical director at Naya Specialty Clinic, Bangalore. Madam is executive committee member of BSOG from 2023 to 2025. Executive committee member of Medical Legal and Ethics Committee, CASO, Board of Director, Maternal and Child Health Rotary, Bengaluru Harmony from 2023 to 2024. Vice President Rotary Bangalore Harmony, life member of BSOG IAGE IMA. And Madam is also authored chapters in obstetrician emergency in JP publication. So I welcome Dr. Aarti Sridhara ma'am also. And I hand over the session to Dr. Aarti Sridhara madam. So madam will take the session further. So over to you, madam.
Good evening, all. Thank you, Nilesh. Thank you, Asha ma'am, for giving me this opportunity. And good evening to all the gathered August. Just a second, please.
Ish, would you display my CV, please? Aarti? So, I think I'll get introduced later. At the outset, I would like to welcome all the dignitaries to this program. And as usual, before we actually start anything, we seek the blessings of the divine. And I ask Nilesh ji, please start the prayer and then we will take the program forward. Welcome everyone to this 21st edition of Searchlight.
वक्रतुंड महाकाय सूर्यकोटि समप्रभा निर्विघ्नं कुरु मे देवा सर्वकार्येषु सर्वदा
Namaskar. I welcome you all to this 21st episode of Searchlite, which is on primary amenorrhea. We have two very respected speakers, Dr. Suvarna Khadilkar madam and Dr. Hafeez Rehman sir, who will be taking us through the diagnosis and management of primary amenorrhea. There are Bijapur, Firozpur, Karnal, Karad, Kotkapura, Kottayam, Kohima, Krishnagiri, Lucknow and Bhimavaram societies who have joined us for this meeting today. And I welcome our chief guest, Dr. Kavita Bapat ma'am, guests of honor, Dr. Sarita Bhalerao and Dr. Preeti Kumar, the conveners, Dr. Sujya and Dr. Aarti. I welcome our speaker, Dr. Suvarna ma'am, and our chairperson, Sarabjeet Kaur ma'am, Nishi Garg ma'am, and Dr. Beena Kumary ma'am. Our second speaker, Dr. Hafeez Rehman sir, and the chairpersons, Dr. Jamir, Dr. Rekha Rajesh, and Dr. Aarti Kaushal. I also welcome our experts, Dr. Jaiswar ma'am and Dr. Shailaja R Bidri, and the panelists, Dr. Dinesh Pathak, Dr. Madhu Goyal, Dr. Sujatha Anbalagan, Dr. Nidhi Johri, Dr. Sheetal Nath Kole, and Dr. Preeti Niranjan ma'am, who has kindly consented to be a panelist here, though she was our chief guest in a previous program. So I welcome all of you, and Kavita ma'am is in a surgery, so I would request the CV of Sarita Bhalerao, please, and then we can start the program. May I have the CV of Dr. Sarita? So, Dr. Sarita is the secretary of ICOG. She's an obstetrician and gynecologist at Breach Candy, Reliance, HNH, Saifi, Bhatia, and Wadia hospitals. She is the immediate past president of Mumbai Obstetric Gynec Society, chair AICC RCOG West Zone, quiz committee chairperson Foxy 2009 to 11, past chapter secretary IMS Mumbai. She's been previously the governing council member of ICOG, joint secretary Foxy 2017, and past president AMWI Mumbai branch. She's also a dear friend and very focused on preventive oncology in the past, just like Saraya ma'am. Welcome, Sarita. We are really honored to have you with us today.
Thank you very much, Dr. Asha. And I must congratulate you on this series that you are having. And today you have taken a wonderful topic of primary amenorrhea. I also take this opportunity to congratulate you for the wonderful conference that you organized in the month of April. I heard that it was really very nice. I can see that you have a galaxy of speakers, and I can see Dr. Suvarna Khadilkar, Dr. Preeti Kumar, Dr. Hafeez Rehman, and so many wonderful speakers here. So I would like to be brief and wish you all the very best for this wonderful series. Thank you so much for inviting me.
Thank you so much. Thank you, Sarita, for taking out time for this. Thank you so much. Now may I have Dr. Preeti Kumar's CV, please? So Dr. Preeti Kumar is the chairperson of Maternal and Perinatal Committee SEFOC, chairperson Safe Motherhood Committee Foxy 2020 to 23, committee member MFM Committee AOFOC, currently joint secretary India Gestosis chapter currently. She is also the professor and HOD obstetric and gynae at Narayana Institute of Medical Sciences, Kanpur. Organizing secretary NARCHICON 2024. She's organized many conferences. She was the vice president of Lucknow Society, and she is a core member of many cells, prevention of violence against women cell of Foxy, recipient of many prizes. And I think none of us really need to be introduced to her because of her extensive work in Safe Motherhood Committee. I think she's a household name in every Foxian's home. She is also going for VP North Zone this year. So welcome, Dr. Preeti Kumar ma'am. Over to you for your words of wisdom and blessing.
Thank you so much, Dr. Asha. Is my voice audible?
Yes, it is.
So thank you so much for inviting me as a guest of honor, Dr. Asha. And first and foremost, whatever I'm today is because of Foxy. And I must thank all the Foxy presidents, Dr. Alpesh, Dr. Shanta, and Dr. Rishikesh Paider, whose guidance I have worked as a chairperson, Safe Motherhood Committee, and of course, the dynamic two leaders, the Secretary General, Dr. Jaideep Tank, who has not taken over as president, and Dr. Madhuri Patel. And of course, Dr. Suvarna ji is here. Thank you so much for always so helping for all the endeavors of Safe Motherhood Committee. So thank you so much. And Dr. Asha, I must tell you that I have been observing you for last 1.5 years. You are very hardworking, very dedicated, and the chain of this series of Searchlight, the topics are always well chosen and the faculty is, excellent, as Dr. Sarita has mentioned. And I quite often join your webinars and I find it very informative. And thank you so much. And today's Dr. Suvarna Khadilkar and Dr. Hafeez Rehman, both of them are, excellent speakers. And I want to congratulate all the president and secretaries of the societies who have joined. I am happy that Lucknow is also part of this webinar. And I'm here to listen to Dr. Suvarna and of course, Dr. Hafeez. And all the best to you, Dr. Asha. We sincerely pray and wish that you succeed in every mission. Thank you so much. And the topic
Thank
is
you so
also,
much.
interesting, and I'm going to listen it throughout. I'm here throughout the webinar. Thank you so much.
Thank you so much, Dr. Preeti. We'll be listening to Dr. Kavita when she joins in. Dr. Suvarna ma'am has had a very bad throat, but she has actually agreed to speak as much as she can. I said that this is a topic I heard a great deal of praise, that Suvarna ma'am speaks excellent on this topic. So I got her for this program, and let's hope her throat lasts till she wants it to speak. So with this, I invite Dr. Aarti to please introduce the chairpersons.
Thank you, ma'am. Sorry for that glitch in the beginning. Yeah. So now we would like to start the scientific sessions, and the topic 1 of the day is Etiology and Medical Management of Primary Amenorrhea, for which our speaker is Dr. Suvarna Khadilkar, and I would like to invite the chairpersons, Dr. Sarabjeet Kaur. Dr. Sarabjeet Kaur. Dr. Sarabjeet Kaur has worked as registrar in Leelavati Hospital, Mumbai. She is secretary Foxy, Firozpur branch, Punjab, in private practice from past 12 years, and she has special interest in high-risk cases. We welcome you, ma'am. And I would like to invite Dr. Nishi Garg. Dr. Nishi Garg has done MD, FICOG. She is the director, Garg Multispeciality Hospital, Faridkot, ex-professor PIMS Udaipur. She has more than 32 years of experience. President KFOGS Society, member of MTP Committee Foxy, member IFUMB, member IMA, member ISOPAT, many credit point MICOG, doing laparoscopy and hysteroscopy. She's an infertility specialist too. She has many publications for her reward, and she is an active member of Inner Wheel and various other social organizations. We welcome you, ma'am. Next, I would like to invite Dr. Beena, ma'am. Dr. Beena Kumary, ma'am, Professor and HOD, Department of OBG, Government Medical College, Kottayam. She is the President, Kottayam Obs and Gynae Society, State Coordinator, Medical Education Committee, Foxy 2223, trainer in PPMD for prevention of maternal mortality, organizing convener, UG and PG examiner, thesis guide, published papers in various journals, and her areas of interest are high-risk pregnancy and vaginal surgery. We welcome you, ma'am, and I would like one of the chairpersons to introduce our speaker, Dr. Suvarna Khadilkar.
Beena ma'am, would you please do the honors?
Yeah, of course. Am I audible?
Yes, ma'am.
Okay. Professor Suvarna Satish Khadilkar is a professor and HOD and consultant endocrinologist and gynecologist in Bombay Hospital, Institute of Medical Sciences, Mumbai. She is the President MOX in 2024-25, Deputy Secretary General Foxy 2021-24, Vice President 22-24, and Secretary MOX 21-22. She's the editor emeritus of Jogi in 2021 onwards, Treasurer Foxy 2018 to 21, and President Indian Menopause Society in 2017, National Secretary Association of Medical Women of India 22-25, President Association of Medical Women of India, Mumbai 2011 to 2016, editor of 12 books. She is recipient of more than 30 local and national international prizes, and she has delivered many orations, keynote addresses. So she's a very sought after speaker. Welcome, ma'am, for your deliberation on etiopathology and medical management of primary amenorrhea. Thank you. Welcome.
At the outset, I want to thank Dr. Asha Jain for having me here. And she was very insistent on me speaking on this. I said, today, out of all my day, I mean, I'm having running nose, bad throat, and hoarse voice. So she said, no, but I'm sure you will be able to pull through it. So we want to hear from you. But I hope I can pull through throughout the talk. And I thank her very much. And it is really to see 21st episode of this Searchlight. Oh my God, how much hard work you are doing, Dr. Asha, since so many days I'm seeing, as Preeti said, it's amazing work that you are doing, and the whole, the team with you is very hardworking, and they are really doing good work. And I can see the chief guest, Kavita, I think she's going to join, Preeti, Sarita, and my co-speaker, Dr. Hafeez. It's an honor to be with all of them. Can I get to share my screen?
Yes, ma'am.
Yeah.
Nilesh, would you do that?
It's a little gray, I suppose.
Sorry, ma'am?
Can I
Please
share
allow
my
ma'am to
screen?
share screen.
Yeah, it is already allowed. So, ma'am, you can just click on the share
Yeah,
screen
it was
button.
gray. Now I can probably hear. It's not happening. Have you made me the co-host?
Just a second.
The button share is gray.
Now try, ma'am. I have made you co-host.
No, it's not happening. I'll try once more. Wait. No.
Suvarna ma'am, you are co-host.
Wait. Yeah, let me see. Can you see?
Yeah, I saw in the participant list, you are co-host.
Can you see the screen now?
Yes.
Yes, ma'am.
Yes, ma'am.
Thank you so much.
Yes, yes.
I have to go for the screen. This slideshow. Wait. Yes. Okay. So the topic is primary amenorrhea. As Dr. Asha said, that I've been talking on this topic since many years, and it has been a topic which is of very close to my heart. But unfortunately, now I had my presentation, which had a lot of material on it, my personal clinical pictures and all. I could not find because of all these issues. But I think this is the better of whatever I have put together. So all of us are well aware by that the definition of a primary amenorrhea would be absence of menses by age of 13 years without secondary sexual characteristics, and absence of menses by age of 15 years on presence of normal secondary sexual characteristics. Absence of secondary sexual characteristics indicates that the woman was never exposed to estrogen and can indicate a medical condition that affects her overall health. Now, when we say exposed to estrogen, this, very interestingly, it can be a exogenous estrogen or endogenous estrogen, because I've seen couple of cases where they never attained amenorrhea, I mean, they never attend the menarche, and they went to the doctors. The doctors just blindly started them on estrogen, and they started developing some secondary sexual characteristics. And after that, they never actually had any menses, and they just stopped at that breast development. So then that some breast development, then that gives rise to some confusion in the minds of consultant who sees it later, and then so we just be sure that it has been exposed to, the patient has been exposed to some estrogen. Now, a study of 102 cases at tertiary care centers showed 47% cases due to Mullerian anomalies, 20.5% due to gonadal dysgenesis, 11% due to chromosomal anomalies, and 7% due to genital tuberculosis. I always tell my students that may it be primary, may it be secondary amenorrhea, the two common causes for amenorrhea are in India are one, pregnancy, and two, genital tuberculosis. I think whichever is the amenorrhea, you first rule out these two common things, and if they're not having TB, not having pregnancy, then go for the other, other diagnosis. So overall, the classification, all of us are well aware. WHO class 1, class 2, class 3, hypergonadotrophic and hyperprolactinemic anovulation. So hypergonadotrophic hypogonadism, when the FSH is generally more than 40 international units, and there is a gonadal dysgenesis, Wire syndrome can be one of the any of the causes. Now, eugonadotrophic primary amenorrhea can be due to Mullerian agenesis, androgen insensitivity syndrome, and there can be normal development. Very, very rarely, I've not so commonly seen PCOS presenting as primary amenorrhea, but occasionally that patients who have very, very severe insulin resistance right from childhood, they also have a PCOS-like picture, and severe insulin resistance syndromes can present as primary amenorrhea. I had one such case, but apart from that, commonly PCOS doesn't present as primary. Usually there is a menarche and then they present a secondary amenorrhea. Then there can be adrenal causes, cryptomenorrhea, tubercular endometritis, constitutional delay, and thyroid dysfunction. These can be the causes of when there is a normal development of sexual characteristics, secondary sexual characteristics. Hypogonadotrophic primary amenorrhea can be due to Kalman syndrome, psychogenic causes, and malnutrition, anorexia, etc. So there can be pituitary and hypothalamic causes like prolactinomas, craniopharyngiomas, adenoma, anticellular syndrome, and there can be hypoplasia of anterior pituitary and pineal gland tumors. So let us see why the cases where hypergonadotrophic hypogonadism exists associated with absence of secondary sexual characteristics. It usually means when there is a high FSH, that means there is the gonadal dysfunction which is responsible. So there is a high gonadotrophic levels, and the common causes would be Turner syndrome, pure gonadal dysgenesis, and mixed gonadal dysgenesis. So this is a classic case of Turner syndrome where karyotype is 45XO, and she grows have a retarded growth, so she remains shorter height. So here, when you diagnose them early, you may have to give growth hormone for initial achieving the normal average height, and then you can give the hormones, estrogens and others, for a further development of the secondary sexual characteristics. These patients may have lymphedema at birth, cystic hygroma, web neck, short fourth metacarpal, pigmented spots all over the body. There can be widely placed nipples and shield chest. There can be thyroid disorders, streak gonads, ovaries, and they usually do not develop breasts at puberty, and they have bicuspid aortic valve is very common associated abnormality, horseshoe kidneys, and these physical other abnormalities are very commonly associated with Turner syndrome. And you can very nicely notice the cubitis valgus in this patient. Now, let's go to the gonads, how they look. These are the streak ovaries from Turner syndrome, and this is how the microscopic picture of Turner syndrome look. Now let's go to the Swire syndrome. I had a very beautiful case of Swire syndrome. Somehow I couldn't find the case in my slide deck. So 46XY genotype. There can be, it is male, but phenotypically reared as a female with sexual infantilism, primary amenorrhea, normal stature, bilateral streak gonads, and some development of secondary sexual characteristics. Infantile uterus is present with few, sometimes occasional uterine bleeding. And interestingly, mutations in the SRY, that is sex determining vision gene on the Y chromosome, located at a particular spot, which is written at YP11, result in XY females without proper gonad development. And very interestingly, some of the Swire's syndrome, when they have uterus, they also have tubes. And if you have an incomplete Swire, you will have one-sided testis development, and there will be tubes which will be absent. The other side, there will be a streak, a gonad, and that side you will find the tube. So very interesting, different grades of complete, incomplete Swire syndrome are seen in practice. And when there is a Y chromosome, all of us are aware the gonads have to be removed for the fear of the malignancy. Congenital adrenal hyperplasia is an autosomal recessive disorder, deficiency of 21 alpha hydroxylase enzyme in more than 90% of cases, decreased synthesis of cortisol and aldosterone, accumulated 20 alpha hydroxyprogesterone is diverted to androgen production, and signs of androgen excess that we see. Aldosterone deficiency leads to salt wasting, and it is rather, a salt wasting disorder, and vagina, uterus are present. And however, there is a female intersex, and there is a this is a common cause of ambiguous genitalia in females. Ovaries are usually polycystic in appearance and ovulatory. Then there are other deficiencies like 17 alpha hydroxylase deficiency. Then there can be ACTH stimulation test can be done. There can be aromatase deficiency, LH receptor mutation. So these are FSH receptor mutations. These are little rarer cases. And primary amenorrhea resulting from hypogonadotrophic hypogonadism occurs when hypothalamus fails to secrete adequate amounts of GnRH, and when a pituitary disorder associated with inadequate production or release of pituitary gonadotrophin is present. There can be a constitutional delay or physiological delay where most common manifestation of hypogonadotrophic hypogonadism may be seen, and amenorrhea may result from the lack of physical development caused by delayed reactivation of GnRH pulse generator. It's normal in terms of physiological development. Anorexia nervosa is a psychosomatic self-imposed eating disorder where, minimal 22% of the body fat that is required for normal menstruation. But here, when there is a puberty, fear is in the mind of the women, girls, and they stop eating. They don't want to get fat, and all the percentage minimum required body fat is not attained at all, which is required to have an onset of normal menstruation. So there can be other causes like Kalman's disease, which is autosomal dominant X-linked recessive gene, anosmia and maldevelopment of neurons, activate nucleus can be there, along with Kalman's disease. GnRH receptor mutation can be there in the causes of signal transduction of GnRH to FSH and LH receptor. This is a classic anorexia syndrome girl. You can see and most common, you all see this very subtly in many girls who are very, ambitious. They want to maintain weight at puberty. They are going in a crash diet when they want to go for any modeling or a film line career. They want to remain thin and fit. They often go in the anorexia nervosa, especially if they have this psychosomatic disorder along with it. So amenorrhea, when it is present with secondary sexual characteristics which are there, and some abnormalities of pelvic anatomy may be there. Primary amenorrhea is caused by congenital abnormality of the female reproductive organs in about 20% of the cases, and this occurs if there is a blockage of the outflow tract. So you will find normal secondary sexual characteristics in these patients. So when there are absent secondary sexual characteristics, there is no estrogen, and when there are secondary sexual characteristics are present, the adrenal function and the ovarian function is normal, but still there is amenorrhea. That means there has to be some mechanical blockage. It could be outflow tract obstruction and normal functioning uterus. There will be all of us are well aware of the collection of the menstrual blood in the so that is a hematocolpos and hematometra, and if it is retained for long, all of us are aware there is a destruction of the function of these the tubes and all. There are times when there is an absence of cervix, which is the worst thing to handle, and there can be further consequences which are, they may lead to hysterectomy. Some of them, we cannot communicate the uterine cavity with the cervix. It's a very difficult task, and however, if you are successful, that is the best thing you can do. And there can be non-functioning uterus which can go missed, and malarial agenesis. So Mullerian anomalies like imperforate hymen, transverse vaginal septum, mere rocketancy, Custer-Hauser syndrome can be there. And some of the developed secondary sexual characteristics you may even see in androgen insensitivity syndrome, where the breast development happens, but clearly there is a tall woman who is hairless and with adult breast development. If you see, it's a classic case of androgen insensitivity syndrome. Plus, there can be other disorders like ovotesticular disorders. There can be absence of endometrium, destroyed endometrium, which often destruction with Asherman syndrome can happen with genital tuberculosis, where other secondary ovarian function may be normal, but the tubes get damaged. Then it could be secondary to cervical surgery, the Asherman syndrome, vigorous curettage, history of bone biopsy, loop electro-excision procedure. But all this can be, in the secondary amenorrhea also. But if it happens too early in life, they will lead to primary amenorrhea. Then this Emarcate syndrome, which is often seen, and we find 15% of causes of primary amenorrhea. Normal secondary sexual development, external female genitalia, normal female range of testosterone levels, absent uterus, upper vagina, and normal ovaries. And karyotype will be Y. I'm sorry, it's a mistake there. I mean XX, it would be normal, this thing. And they may have renal, skeletal, and auditory abnormalities. Androgen insensitivity syndrome is, again, I just described. The test is often palpable in the inguinal area. Labia produce Mullerian inhibitory substance that induces the regression of the Mullerian structures, fallopian tube, uterus, and upper 1/3 of the vagina. And serum testosterone is in the normal male range, and they are tall. And very often, the lower 1/4 of the vagina is rather well developed. And if such women get married, because they are beautiful looking, why? Because they are hairless, they are tall, they are breast developed, and but they get married also, and they also have, they develop sexual satisfaction also, because 1/3, I mean the lower one pouch of the vagina they start developing. But of course, the husbands do understand there is some problem. There cannot be a deep penetration, and then they are brought. So such rare cases, when they don't want to reveal that there is a amenorrhea, they get married and they come back with a sexual difficulty. If this is the classical AIS with well-developed secondary sexual characteristics, but absolutely paucity of hair and long stature. This is the ovotesticular disorder where both male and female gonadal tissues are present in these patients. Both Mullerian and Wolffian structures are present and correspond to ipsilateral gonad, and there is a ambiguous genitalia varying with the amount, how strong or how much is the tissue, wearing tissue there. Accordingly, the ambiguity will be present. Now, when there is a normal pelvic anatomy, the complete list of potential causes is long, but the most common cause with normal secondary sexual characteristics and normal pelvic examination are, as I already told you in the beginning, pregnancy, rarely PCOS, where early young girls may have hyperprolactinemia, thyroid disease, and a very, very interesting premature ovarian failure where they have hardly any, they don't even have any slight bleeding, no bleeding. They don't understand it was a period, and the ovaries are already kind of, there is a premature insufficiency, as we call, rather than failure. So, and hypothalamic dysfunction, all these can be the cause with this. So I'm just skipping the PCOS, and I want to go to, evaluation of primary amenorrhea, the detailed history, family history, and thyroid disorders, symptoms. You must ask weight changes, bowel complaints, physical examination, height, neck. Very often you must not forget to do the span and measurements, which are very, very important. Note the stage of breast development, axillary and pubic hair, what stage of development they are, nipple discharge, hematocolpos, headache, acne, and acanthosis nigricans. So these are the galactorrhea. Whether if there is a breast, you see for galactorrhea, it could be with prolactinemia, condition more commonly associated with secondary amenorrhea again, but sometimes even in primary you may see with normal secondary sexual characteristics. These are the tests that you do. I always say the two important tests in primary amenorrhea: first, clinical examination; secondary, sexual characteristics. Once you see breast, except for AIS, breast development means estrogen is there. Estrogen is there means there is a ovary which is functioning. So mostly the FSH is going to be normal. But you want to complete the list of investigation, you can do FSH, LH, estrogen, androgen levels. See, for a good experienced clinician, the whole battery of investigation is hardly ever required. I remember a case where one patient was brought in to my OPD from outside, and they said, "Madam, this is a case of fibroid uterus." And it was an open case, open and shut case outside in primary, in a private clinic. And they couldn't understand what it was. So they opened the abdomen, closed the abdomen, and they referred to tertiary care center. She came to me. I just examined. I asked her history. She gave history that she had her menses, but I doubted because the development of breast was not that complete, not like, like an adult, this thing. So I asked her. So then she convinced, and she just confessed that she was taking some medication to get the periods, and she was getting the periods. And at the age of 35, she came with a huge tumor which was interpreted as a fibroid uterus. And I only told the resident, don't do anything. If you want to confirm the diagnosis, do her karyotyping. I am telling you, it will come XY. And they were looking at me, "Madam, how can you just die? Fibroid uterus, I'm telling, there is some breast development, and you are telling me to do karyotyping." I said, "Just do and come back to me." And they did it, and it was a XY. It was a Swyer syndrome. At the age of 35, she developed that gonadoblastoma. And that's why she didn't go, when she went to a private hospital, They did not understand when they opened, it was not looking like a fibroid. So very wisely they closed, unfortunately, or whatever. And then they brought, then finally we diagnosed, we removed the tumor, we treated, we also did the other side. There was a whatever that gonad was there, we did gonadectomy, and we finally put her on the hormone therapy lifelong. So this is the diagnostic workup that is given, various other associated tests you can do. But I want to go to, cut short the talk. It's a very complicated chart, but it's a very, very important chart that I have personally made it. And you will find this in my book, Endocrinology for OBGYNs. And if you start looking at primary amenorrhea, as I said, first look at the secondary sexual characteristics. If present, yes, pregnancy test. If negative, then you go for pelvic ultrasonography. If positive, you know what the diagnosis is. If pelvic sonography shows uterus is absent or abnormal, do the karyotype analysis. If normal uterus, then uterine outflow blockage may be there. If you find there is some blockage there or collection there, then you know what the diagnosis is. And if there is no blockage, then evaluate other causes of secondary amenorrhea, which may be coming for very early on for this primary amenorrhea. Then if uterus is absent, karyotype shows 46 XX, then it is Mullerian agenesis. If it is showing 46XY, then it is possible androgen insensitivity syndrome. Now we go to the other side. When the secondary sexual characteristics are not present, do only the most important test, that is FHS. If FSH is less than 20, then measure prolactin, do brain MRI and thyroid function test, and you find out any abnormal function, thyroid, hyperprolactinemia, and there can be a structural brain abnormality. Very commonly, you may find any tumor in the pituitary or anywhere, hematomas or some other space occupying lesion may be seen. And if FSH is normal, and if you find there is a virilization, then measure the androgen, testosterone. If they are high, it is a hyperandrogenic anovulation. If they are very high, then you are looking at an androgen secreting tumor, as you can see in the chart at the lowermost part. And if you find that the testosterone and DHEAS are normal, then evaluate for other causes for secondary amenorrhea, like any adrenal. You can do MRI for androgen secreting ovarian or adrenal tumor, and if they are normal, then evaluate for other causes of this. Now, if there is assess the bone growth, if there is FSH is normal, no virilization, assess the bone growth. If there is a delayed bone growth, you are looking at a constitutional delay or growth and puberty. So this is how this is. If you look at this chart and keep it on your table, just go step by step, you will come to a diagnosis, most probably at a clinical setting only, and only 1 or 2 tests you will require. And the karyotype, most of the times you can clinically say that this is going to be XY or this is going to be XX, but you have to do that test to endorse it, that what you're saying is correct. So the medical treatment, whenever there is a syndrome where there is a premature ovarian insufficiency or failure, you have to give them hormones. It can be initially start with 0.3 to 0.625 milligram of conjugated estrogen or oral estradiol 0.5 to 1 milligram. You can give daily in combination with progesterone, medroxyprogesterone, or you can also give the micronized progesterone. You can give 100 milligram every day of the, at a daily dose of 100 milligram of the month, or 200 milligram daily for at least 12 to 14 days of month. If the uterus is responding, she will get the period, but it is just the cyclical period because her ovaries are not functioning. It is just the hormone dependent period. She will get mentally satisfied that yes, but more importantly, these hormones will help her for maintaining her bone health. and other, it's like a menopause at young age. So you want to give her hormones to maintain her bone health, and other health benefits, even cardiac benefits, are known to happen with the or hormone therapy early. If the patient is short in stature, like somebody like Turner syndrome, as I told you, delay the hormone therapy till the time her growth is attained to her normal level or normal desired. You have to calculate the mid-parental height. First, calculate what's the height of mother, what's the height of father, and calculate the mid-parental height, and then take the desired height. Till then, she may require Turner syndrome's required growth hormone injection for years till she attains a good height, and then you start giving her estrogen and progesterone to get the cyclical periods. Now, I'm not going for a surgical treatment, so I'm skipping some of the slides which I have given. Now, hypogonadotrophic amenorrhea, clomiphene citrate is often ineffective for inducing ovulation, especially if there is a hypogonadism to desire pregnancy. So you may have to go for the injectable gonadotrophins ovulation induction for getting ovulation. Maybe she will require assisted reproduction, and if there is no ova at all, and if she's desirous, again oocyte donation may be the answer. Geminomas are highly sensitive to radiation and chemotherapy, therefore surgery is rarely indicated. Now, patients with Kalman syndrome and other etiologies for hypothalamic amenorrhea can be treated with, again, hormone replacement. The patient has physiologic delay of puberty. The only management required is the reassurance she will get the periods, and a little bit of advantage that she will grow taller. The bones epiphyses don't close, so she will become little taller here, but otherwise she needs reassurance and she will get a period a little later. Then individuals who have Y cell line, obviously we all know they need removal of gonads at appropriate age. It's not that all Y cell have to be removed immediately. So because we need to give them some hormones for the health. So that has to be whether it is an incomplete, that is mosaicism. So there is a good combination of different disorders, and then you take a decision when to remove the. So most probably the at age of 25, 35, the 25% of the Y cell line gonads, they undergo malignant change. I'm going to skip the surgical line of treatment because I think the next speaker is going to say. So I think I'll go straight to end my talk on the medical management. I've done it very briefly, but I thank you all. Because of my lack of health, I could not work more on the presentation. And I thank once again for you for having me here and giving me this talk. Thank you so much.
Thank you, madam, for that excellent talk.
Strong.
Because no, such a difficult topic, and once the patient of primary amenorrhea approaches you, it's a meticulous history taking and meticulous examination, and the investigation that you do should be to the point. There's no need to do all the investigations in all patients.
Yes.
So that workup, you have done it excellently. So thank you very much for that wonderful talk.
Thank you so much, Dr. Suvarna. You said that I prayed that your throat would last, and it did last. So thank you so much, because our panel is going to be based on what you have taught us right now.
Yes. And that's actually my other presentation is full of cases. Then I thought there is no point in giving that because you are going to have the panel. So I chose this. Thank you so much.
So we will have that, and this was quite comprehensive. I've taken a screenshot of that chart that you made and I've pasted it in the group for everyone.
It is already there in my book also. So anybody wants to refer to my
Yes,
book,
ma'am.
we can take that. Thank you.
Yes, ma'am. Thank you so much. Thank you.
Thank you, ma'am.
Dr. Aarti,
Yes, ma'am.
for the next chairpersons, please.
Yeah. Thank you, ma'am. And it was a wonderful session. you all the chairpersons for being here. Now I would like to call upon our next speaker, none other than Dr. Hafeez Rehman. Good evening, sir. And I would like to invite the chairpersons of the day, Dr. Jamir. Can I have his slide, please? Dr. Jamir, Secretary, Kohima Obs Gynae Society of Nagaland, Consultant and Head of the Department Obs Gynae, CIHSR Nagaland. He has published papers in both national and international journals. We welcome you, sir. Dr. Rekha Rajesh, it's my honor to introduce. She is my classmate too in my days. And Dr. Rekha is at present, she is an honorary she is a president of Obs Gynae Society of Krishnagiri at present. She has done a diploma in reproductive medicine, PG diploma in reproductive medicine, Warwick and Germany. She has certified high-risk pregnancy. She has certified high-risk pregnancy specialist, master's certificate in reproductive medicine at Homerton University, London, clinical director, Vijay Srishti's Fertility Center, Krishnagiri, director of Matrutva Fertility Center, Tirupati and Nellore. She is life member of various other associations. Next, I would invite Dr. Aarti Kaushal, consultant, Life Care Hospital, Karnal, Haryana. She has done her MBBS from Government Medical College, Amritsar, MD Obs Gynae from NHL Medical College, Ahmedabad, President of Karnal Association of Obstetrics and Gynecology. I would like, and she has special interest in high-risk pregnancy. She is a treasurer of IMA Karnal, member of FOXY IFS Mission Pink Health, Haryana. We welcome all the dignitaries, and I would like one of the chairpersons to introduce our speaker, Dr. Hafeez Rehman. Dr. Jamir, can you please introduce Dr. Hafeez Rehman?
Hello, am I audible?
Yes, sir.
Yes, sir.
Okay. Yeah. First of all, to thank Dr. Hafeez Rehman for accepting to be a speaker on this special and interesting topic. He is the chairman, Sunrise Group of Hospitals. He was the former board member of MCI and large number of world in this hospital and special.
Sir, not audible, sir. He has.
Dr. Rekha Rajesh, would you please take over, please?
Yeah. Sir,
Yeah, am I
Hafeez
audible?
Rehman sir has magic in his fingers. I've seen him as a student, and he's one of the best laparoscopic surgeons in India. And he has a special interest in gynec oncosurgeries, endometriosis, and pelvic anomalies. Over to you, sir. Thank you so much for being part of this.
Yeah, thank you so much. First of all, Dr. Jain, thank you so much, and the organizers for inviting me for this nice gathering. And I had an excellent speaker before me who has clearly elaborated everything about primary amenorrhea. Now, I'll be concentrating mostly on the surgical aspects of primary amenorrhea. When I talk about surgical aspects, it's mainly the cryptomenorrhea part of primary amenorrhea. So let me share the screen. Can you put the share on?
Nilesh?
I'm not able to share the screen. Yeah. No.
Nilesh, please make sir co-host. Sir, you are co-host now. Hafeez sir, your co-host, sir, you
Right.
can share.
Yes, yes, I'm trying. I think it takes a little time or what. I'm not able to share it.
So you are co-host, you can share it.
It's coming as gray only. That share thing is coming as gray. Should I go into this advanced thing or basic only?
In basic only we can share it.
Yeah, but it's not coming.
Nilesh, could you help, please?
Can you share it to me, sir? Or WhatsApp me?
So we can see you as co-host. So I don't know why
Yeah,
the
but
problem
that
should be
share is
that.
gray. When I put the share screen,
It's
I
not
can
green.
optimize the video clip and share the sound, but the share part is coming as gray.
Now try, sir.
Yeah, 1 minute. No. Now I think I'm not able to optimize the video also.
Nilesh, if sir leaves and joins again, will it help?
Yeah, that can be done.
Sir, would you
try
leave
that.
for a second and join again?
Yes, yes, yes.
Once sir joins, please make him co-host immediately.
Okay.
Welcome back, sir.
Yeah.
Is it green now?
No.
Oh, it's showing
Still
that
gray.
you
I
are
think something has
co-host.
to be done from their side only.
It's showing that you are co-host, sir.
Yeah, but can you change me as co-host and then put me again?
Yeah, I can do it, sir. Now try, sir. I have again made you co-host. Lastly, I can do that. I can make you host and then you can share the screen and after webinar, your session, you can again make me make me host.
Now, can you then put it as host?
Yeah. You are host now, sir.
Sir, is it green now?
No, it's not.
Sir, there's something wrong with your setup.
Maybe let me just.
So can you share the PPT to one of us, sir?
No, just.
Sir, is it working? Hafeez, sir?
Sir has left.
So, no, he's there.
Now he.
Yes, ഒന്ന് പെട്ടെന്ന് എൻ്റെ ലാപ്ടോപ്പിൽ ഒന്ന് കയറുമോ? അതിലെന്താ? ഹലോ, ഒരു സൂമിൽ എനിക്ക് ആ വീഡിയോ ഷെയർ ചെയ്യാൻ പറ്റുന്നില്ല. ഒന്ന് നോക്കിയേ. അതിലാ ഏതാ എടുക്കണ്ടേ കയറാനായിട്ട്? അതെവിടെ ഇരിക്കുന്നത്? അതില് നമ്പർ വേണം. അല്ല, യുവർ അഡ്രസ് അല്ലേ? 1463347405. അതിൽ ഇൻവൈറ്റ് ചെയ്യട്ടെ ആദ്യം. One 463347405. Okay, accepted. ഇത് ക്ലോസ് ചെയ്തേക്കട്ടെ, എനി ഡെസ്ക് ക്ലോസ് ചെയ്തേക്കട്ടെ. ഇപ്പൊ മറ്റേ ഇതില് ഷെയർ സ്ക്രീൻ ഷെയർ ചെയ്യണം. എന്റെ ഷെയർ സ്ക്രീൻ വരുമ്പോൾ ഷെയർ സൗണ്ട് ഒപ്റ്റിമൈസ് വരുന്നില്ല, പിന്നെ ഷെയർ സ്ക്രീൻ വരുന്നില്ല. ആ ഷെയർ ഗ്രീൻ ആവുന്നില്ല അവിടെ. എനി ഡെസ്ക് തന്നെയാണോ?
Yes. It is visible now.
അല്ല, ടോട്ടൽ ഇല്ല. ആ ഷെയറിന്റെ ഒരു മിനിറ്റ്. ഷെയറിന്റെ ആരോ അഡ്വാൻസ്ഡ് ഇതല്ലേ? കിട്ടിയ? മൾട്ടിപ്പിൾ പാർട്ടിസിപ്പൻസ് can share simultaneously. മുകളിൽ കണ്ട അഡ്വാൻസ് ഷെയറിംഗ്. ഇതിൽ സ്റ്റോപ്പ് ഷെയറിംഗ് എവിടെ? ഈ അഡ്വാൻസിലോ? സ്റ്റോപ്പ് ന്യൂ ഷെയർ അല്ലേ മുകളില് ആ ആ ആ ഷെയർ കൊടുത്ത് സ്ക്രീൻ എന്ന് പറഞ്ഞാൽ അഡ്വാൻസ്ഡ് എനിക്ക് ആ അത് കിട്ടി പിന്നെ അതില് പവർ പോയിന്റ് വിർച്വൽ ബാക്ക്ഗ്രൗണ്ട് ആ ലിങ്ക് അല്ല ആ പവർ പോയിന്റ് ഷെയർ ഓപ്പൺ ചെയ്യണം ആ അല്ല ഇത് ഷെയർ ചെയ്യാൻ പറ്റുന്നില്ല ഇല്ല ഇത് ഷെയർ വന്നിട്ട് ഇങ്ങനെ നിൽക്കുക ആ ഇപ്പൊ ഷെയർ കണ്ടന്റ് ഫ്രം സെക്കൻഡ് ക്യാമറ ആ ഇപ്പൊ ആയി ഒരു പോലെ you have shared your screen പക്ഷെ എനിക്കിപ്പോ എന്റെ സ്ക്രീനിൽ കാണുന്നത് എന്റെ പിക്ചർ കാണുന്നത് ഒന്നുകൂടി സ്റ്റോപ്പ് ചെയ്തിട്ട് Can you see my screen now?
Yes, yes,
Yes, sir.
it is visible.
I'm so sorry for the confusion.
Just make it slide.
So you can see my slide now?
Yes, it's clearly visible, sir.
Okay. Now, so today we will be talking about the surgical management of primary amenorrhea. So basically, I'm talking about cryptomenorrhea. And the topics which we will be discussing today is basically the transverse septum, transverse vaginal septum, isolated cervical atresia, and vaginal agenesis. See, what we need to understand is that these kind of surgical management, it has to be done in a place where it is regularly done. Because what we have seen is many times we see a lot of surgeries being done on it. And many of the times we see that there are a lot of wrong surgeries done on this kind of cryptomenorrhea. And it should be understood that the primary surgery would be the most ideal procedure, as what we say usually in other procedures like endometriosis also. Now, transverse vaginal septum, you'll feel it's very simple case of vaginal septum, but not always. Many times we will find that this can be really complicated kind of transverse vaginal septum because there are different kinds of transverse vaginal septum which we can see. If you look at the embryology, can you hear me properly?
Yes, sir.
Oh, yeah. If you look at the embryology, you can see on the left side, you can see the sinovaginal bulbs which come and the Mullerian duct which come, and in the middle, it fuses here, and then it forms the vagina. Now, what you need to understand is that when we look at clinically transverse vaginal septum, it is just a fusion defect. But clinically, when it comes to you, it can be a fusion defect, or it can be something like a mid-vaginal atresia. Mid-vaginal atresia means it's not just a problem of fusion. In fusion, what happens is there is cannulation of this part of the upper part of the vagina. There is complete cannulation of the lower part of the vagina. And just that these two canals are not fused, and the septum will be hardly 1 centimeter of septum. It is very easy to operate on these type of cases. You can just cut the septum, especially easier when you have a hematocolpus which is there. Now, I'll just show you a picture, a case where we have seen this patient, not actually primary amenorrhea, but a septum which has come to us. And you can see here, this is a blind vagina when you put in the speculum, but the patient says that she is having regular menstrual bleeding. So the diagnosis was a septum with a small hole somewhere. We could not find out exactly the hole. So the problem in these kind of septum is basically you will not understand where exactly the incision has to be made. Because the incision is made at a lower down, your dissection can go right into the rectum. If the incision is made bit anteriorly, it can really go into the urinary bladder. So for understanding this phenomenon, what we did is we went laparoscopically in this patient, and you can see here, when we went laparoscopically, you can see a normal uterus there, and we dissected the bladder down. And this is where we dissected the bladder nicely down. And you can see here, once the bladder is dissected down, and I opened, the idea was to open into the upper part first, dissecting the bladder down. And once you dissect the bladder down, you can see that there is no chance of injuring the bladder. And since the entire surgery is done anteriorly, will not go anywhere near the rectum. So it becomes much more easier. And as you can see here, we'll just bulge from the lower part. I'm just pushing the transverse septum, bulging onto the upper part also. And we'll put an incision here so that I'll enter into the upper part of the vagina. As you can see here, I'm just putting an incision here and entering into the upper part of the vagina. That is a bulge which is there. We'll just enter into the upper part here by putting a vertical incision. And once you put a vertical incision and enter into the upper part, you can easily cut the septum from here itself. See here, the advantage is you can see the bladder is in my hand. So there is no question. I know where the bladder is. This is the bladder. So there is no question of injuring the bladder. And rectum will be far down. As you can see, I have entered into the upper part of the vagina. And now we are cutting the transverse septum. The rectum will be far down posteriorly. So there is no chance of injuring the rectum in such cases. So I'm just elaborating some new methods which will be much more useful rather than getting into the textbook methods as usual. So this kind of a procedure can be much more useful and much less complicated for these kind of transverse septum which are thin. Now, this is useful, even vaginal procedures, it is useful only for transverse septums which are less than 1 centimeter. Rather, I would say that we classify transverse septums only less than 1 centimeter as classical transverse septum, not otherwise. And as you can see here, you can have a pull through of the septum and you can close the vagina and it becomes a completely normal vagina. What we are doing is we are just taking the upper part of the vagina and the lower part of the vagina and then suturing it so that it will become a completely normal vagina, as you can see. Do not incise the transverse septum and just leave it. So it should be a completely normal vagina only when you suture it as such, and this is the hysteroscopy part of it. Now, at the same time, this fusion, if you see, if this fusion is more than 1 centimeter, sometimes 2 to 3 centimeters thickness will be there. 2 to 3 centimeters thickness will be there for this fusion. Then what happens is it is completely a different pathology and extremely difficult to deal with. Entire area will be a very fibrous tissue there. And if you put an incision somehow and reach the upper part, or if you put an incision from above and lower part, it doesn't usually work because their incision of transverse septum doesn't work. You need to excise this entire area completely. either with a resectoscope vaginally, or you have to go laparoscopically and excise this entire area. This is a patient who had transverse septum surgery thrice. She had come to me all the way from Assam. She had 3 times transverse septum surgery. Then we also did the 4th transverse septum surgery. And the 4th one actually was, we saw that there was a cervical agenesis also for this patient. And then we had reconstructed the cervix, and we have put a Foley's catheter inside, and then excised the transverse septum. And that's the time when I saw that even the 4th time, it again closed down. You can see it has almost closed down completely. I could not put even a sound. Now we are putting a small histoscope into it, into this hole, and then we are seeing inside what is happening. So we had put a resectoscope, and you can see with the resectoscope, I'm just cutting. You can see the thickness of the transverse septum. It's a very thick one, almost 3 centimeters of septum is there. So we are cutting it completely, and you can see the fibrous material. It's not that I'm getting into the lateral vaginal wall at all. It's a complete thick fibrous material, as you can see. And when we go inside, and as we go inside, you can see the almost 3 centimeters of fibrous tissue was there. And you can see the Foley's catheter inside, the yellow Foley's catheter seen inside, which is still there. And that is on the other side. So we have to incise it. Now, does incision alone, you can see the Foley's catheter now, does incision alone work? If I just incise it and leave it like this is a vaginoscopic surgery. If I just incise and leave it like this, it is going to definitely recur again and again. So that's a Foley's catheter used for reconstruction of the cervix. You can see the nice cervix here on that side, completely reconstructed. You'll not see much of a cervical canal because it's a reconstructed cervix. So what we did is, we know that this fibrous part, if I leave it, it is going to again recur. So what we did ahead is, we took a resectoscope loop electrode and started resecting this entire fibrous tissue here. As you can see, that fibrous tissue is completely resected, and then only the patient was much more comfortable, and till now it has not recurred. So it's very important to deal with these kind of transverse vaginal atresia, or what you call as mid-vaginal atresia. Now, one problem is when you resect these kind of fibrous tissue vaginally with a resectoscope, you need to really keep a mold for a long time. A better method would be to go laparoscopically and then resect that tissue completely, and then suture the upper and lower part of the vagina, where the mold need to be kept only for 1 or 2 weeks, and it heals very well. As we can see, so much of material has to be resected in the, it took something like a TCRA. Basically, you need to resect all the fibrous tissue till you reach the paravaginal tissue. We can identify the paravaginal tissue when you reach it. Can you see that? This tissue is less fibrous, as you can see here. As you resect the myoma and all, when you reach the myometrial fibers, you'll identify the myometrial fibers. So like that, you can actually resect it completely. And this is the only thing which will work in these kind of cases. Now, if you see in this case, this is a laparoscopic approach which we are using for these kind of septum. This is what we do is we dissect the rectum down. This is the rectum which we are dissecting posteriorly. This is the rectum here, and this is the posterior. We are taking the denuvulus fascia. We dissect the rectum completely right up to the perineum, and then go anteriorly also dissect the vagina right up to the urethra. Because until and unless you dissect it completely, you will not be able to excise the vagina as such. Now what we do is we open the vagina again from the upper part, as you can see here. And one thing is, see, all these vaginas need not have collected blood. Some of these cryptomenorrheas, we have seen that mucus material will be there in the vagina. This is not a Nabatean follicle. This is actually the upper part of the vagina, which we have opened. You can see mucus material, and there is no blood as such. This is not very uncommon. So you can see the lower part of the vagina here, which is opened here. That's the lower part of the vagina. You can see my finger there. That white thing, that's my finger. That's the lower part of the vagina. Now, if I just join this upper and lower part, it doesn't work at all. We need to resect this part of this fibrous tissue here, has to be resected completely, and then only it's going to work. So what we are going to do is, that's how we resect the fibrous tissue there. You can see that fibrous tissue there. It has to be completely resected, and then we join the upper and lower part of the vagina. Then only it is going to really work, as you can see here. And you can remove that tissue through the vagina itself with an Alice forceps. And then you can suture it. See, so much of tissue is left there. All this fibrous tissue has to be removed. Actually, you're removing almost a mid part of the vagina completely, because this is very important, and these kind of lesions are not very uncommon. We have got a lot of these kind of recurrences of transverse septum. Whenever you get a recurrence of transverse septum, understand that this is not actually a transverse septum, but you are dealing with a mid-vaginal atresia. So until and unless you resect this vaginal part, see, this complete fibrous tissue has to be resected out and removed. And until and unless you do that, you will keep on getting recurrences. Now, after removing this fibrous tissue, what we do is we suture the upper and lower part of the vagina. As you can see that this is the lower part of the vagina, and here you can see the upper part of the vagina. And you can see how we will suture it. We'll put a Foley's catheter inside, and then you can suture it properly. And you can see there is a mold which is kept. Sorry, not the Foley's. Actually, we are. Oh, wait. Sorry. So this is the upper part of the vagina and part of the cervix. And we have sutured it here. And then what we are doing is we are keeping a mold inside, as you can see here. And this mold can be sutured onto the vulva here. There is a hole in the mold. And that is sutured onto the vulva. And this mold is kept for almost 2 to 3 weeks. Now, isolated cervical agenesis is something, again, which you need to understand for cryptomenorrhea. You will see a normal looking lengthy vagina, but you will find that the vagina is quite blind in the end. As you can see here, this is an isolated cervical atresia. You can see a normal vagina, but a blind end in the upper part of the vagina, as you can see. And these patients usually come with hematometra and primary amenorrhea. As you can see here, most of this cryptomenorrhea, as you can see, will always have endometriosis, because this is quite common, because the overflux of endometrium into this into the pelvis. You can see the tubes are patent. So in those cases also, we dissect anteriorly, the bladder is dissected completely, and posteriorly the rectum is dissected. And in these cases, there are two methods which you can do. One is you can reconstruct the cervix. And in reconstruction cases, we have had almost 20% of restenosis of the cervix. Then what we did is we started taking the appendix of the normal patient and using the appendix for reconstructing the cervix. This is the posterior, which you can see we are dissecting the rectum down posteriorly, as you can see. And this is the upper part. You can see the endometrial cavity is up to here near the internal os. Rest of the area, you can see it's a very fibrous tissue there. So either you can reconstruct the cervix and make a cervical canal, or what you can do is you can do a complete trachelectomy. See, this is the upper part, this is the lower vagina. See, you can see the vagina here. You can see actually the, are you seeing my cursor? You can see the endometrium here, you can see the vagina. So this much part of the vagina cervix has to be excised here. As you can see here, this is the lower part. Here you can see the lower part of the vagina, and we are excising this part of the cervix almost completely. So it's like a trachelectomy which we are doing. You don't have to be much bothered about the uterine artery in this case. Only the descending cervical will come in your on your way. So we are excising that part of the cervix almost completely, and then we will attach the vagina onto the uterus. Basically, there won't be any cervix. We'll attach the vagina onto the uterus. The only problem these patients have, we have had three cases, actually not vaginal atresia. We had three cases. We have cases of radical trachelectomy. And these cases, the only problem which we have is basically cervical incompetence, and you need to put an encerclage once she becomes pregnant. We did not actually put an encerclage in the pre-pregnancy stage because we didn't know whether that would be a problem for the pregnancy as such. So here you can see that we are putting a Foley's catheter, and then we are attaching the vagina onto this uterus, as you can see here. We'll attach the vagina onto the uterus. So this is the vaginal part, and this is the uterus. And that vagina is actually anastomosed onto the uterus. And this Foley's, what we do is we suture the Foley's onto the uterus, and the Foley's will actually fall off after 45 days. Previously, we were using Vical, but problem with Vical is that even after sometimes 10 days, the Vical will disintegrate and it will fall off. So we are nowadays using, can use PDS, or even VLOC is fine. The bar sutures, that is also fine. That will also stay for a much longer time. And this is how you attach the vagina. The results of these kind of surgeries are excellent because the patient is very happy, so it resumes spirit. And that's the posterior part of the vagina being sutured onto the uterus here. So it's important to put the mold or the Foley's inside in these kind of patients to avoid restenosis. You can see the Foley's there. So in case of reconstruction of the cervix, we have had almost 20% of restenosis. The problem is once the restenosis occurs, it becomes very difficult for us to manage in those cases, and very difficult to do trachelectomy also in these cases. Now, there can be cases of complete vaginal agenesis. The entire vagina is absent as such with a functioning uterus and hematometra. Most of these vaginal agenesis I have seen doesn't have the cervix also. So it's mostly a cervico-vaginal agenesis which usually we get. In these type of cases, here you can see a unicornate uterus with a complete vaginal agenesis, and you can see a unilateral unilateral endometriosis. Whenever you see unilateral endometriosis, you can see there is absolutely no endometriosis on the right side. So whenever you see unilateral endometriosis, you should understand that there is a cryptomenorrhea, there is a unilateral cryptomenorrhea. Here it's because of the unicornate uterus. So in this case, what we are doing is we are dissecting the bladder, and the rectum is dissected down as such. And you can see we are putting an incision onto the, that's the rectum being dissected down. And then an incision is put at the vulval edge. Vulval area. We don't dissect it from below, because I believe that we will not be able to, whenever you dissect it from below, will not be able to properly get the correct vaginal plate. Now, in these cases of vaginal atresia, you should understand there is something called as the vaginal plate which is there. Not the vaginal septum, but the vaginal plate which is there. Until and unless you do two things like resection completely of the vaginal plate and cutting of part of the levatrinae. The medial part of the levatrinae has to be cut in these cases. If you do not resect that vaginal plate completely, and cut the medial part of the levator, and we have seen that many of these cases go into more stenosis. Now, we do not dissect it much from the lower part because the plane which you will get from the lower part is completely different. It is much easier and much better planes, avascular planes you will get from the laparoscopic view, as you can see here. And you can cut that vaginal septum here and dissect it completely out. And after dissecting the vaginal septum, we inject methylene blue. You can see that this is the uterus and this is the cervix, which you can see. The endometrium is there up to here. Where the methylene blue is stained up to here, the endometrium is there. So in these cases, either you can resect, you can do a trachelectomy, or you can reconstruct the cervix. This patient, we have reconstructed the cervix with a Foley's catheter. So we have made a groove on the cervix, as you can see here. A complete groove is made on the fibrous cervix, and then a Foley's catheter is introduced from vaginally. You can see this is the endometrium here, and this much is the cervix. A Foley's catheter is introduced from the vagina through the vagina, and you can see that we'll cover the Foley's catheter with the cervix as such here. As you can see here, you can cover the Foley's catheter with the cervix. So this is the cervical reconstruction which we are doing. Either you can use a Foley's catheter, or what you can do is you can take the normal appendix. The normal appendix of the patient can be taken and it is threaded on the Foley's catheter, and the appendix comes at the level of the cervix. So this will act as a mantle to prevent the reconstruction of the cervix. Now the question is, how do we reconstruct the vagina? We have tried all methods of reconstructing the vagina. We have had plastic surgeries, amnion, the gracilis flap has been tried. We have tried the skin, everything does not, none of these procedures have a good results when it comes to the complete vaginal atresia with the uterus. In these cases, you need a proper conduit. You need a muscularis, you need a mucosa, you need the serosa, you need a proper conduit, you need a tube-like thing which has to be fixed onto that area. So that is how we started doing ileal reconstruction of the vagina. So here you can see this is the ileum which we are taking. The vascular ileum is taken. You can see this is the pedicle which we maintain, and this much of almost 10 centimeter of ileum is taken, 14 centimeters away from the ileocecal junction. And the ileum is kept in the place of vagina, and you can suture the ileum. Lower part is sutured to the vulva, the upper part is sutured onto the cervix here, and this part will actually, you can see that ileum down here, and you can pull the ileum upwards and suture it, engulfing the cervix completely, so it will form the colpos. As you can see here, I'm not sure how much clarity you're in. That's the ileum. You can see the ileum, and you can take the ileum and suture it onto the uterus rather than onto the cervix. So it will form a proper colpos. It will form a fornix also will be formed, and it works quite well. And the patients start menstruating, and she can actually have a normal pregnancy also. One of the biggest problem with normal pregnancy in these patients is that the cervix actually doesn't work, and many of these patients have to resort on to intrauterine insemination. And understand intrauterine insemination can be quite difficult, and it has to be done with the help of a resectoscope and cannula. So that's how we reconstructed the cervix. Here you can see the vagina. This is the vagina, rather the ileum. And you can see how the posterior as well as the anterior is reconstructed. That is the posterior part of the ileum, posterior cervix, which you can take and suture it onto the cervix. That's the ileum, which is taken and sutured onto the cervix. And this is the vascular part. Vascular loop is there on the ileum, and it works extremely well. Now, let us look at problems of long-standing cryptomenorrhea. This is something which I need to really highlight. These cases of cryptomenorrhea has to be identified at the earliest, rather at menarche, within 1 or 2 periods. If she has severe pain during that time of, it's not that amenorrhea will be there, cyclical pain at the age of 11 to 12 years has to be investigated for proper cryptomenorrhea. But understand one thing, at that age, you will not always find a hematometra which can be diagnosed on an ultrasound. So during that age, I would suggest that an MRI would be a much more ideal method, so that you can understand whether the vagina or the cervix is completely cannulated. On ultrasound, it will be difficult to understand if you do not have a hematocolpus or a hematometra, to understand whether the cannulation is there as such, because you will not be able to see the mucosa properly on an abdominal ultrasound at that age group. Because the problem of long-standing cryptomenorrhea is that we can have DNA changes. I'll tell you why. Because what has happened to me, I have unified at least 15 cases of functioning uterine horns. Whenever I have unified the functioning uterine horns above 8 years of menarche, the age of menarche, or rather 8 years of hematometra, all of these patients landed up in severe menorrhagia. In fact, I had to even resect out the unified horn to control the menorrhagia. So doing little research on this, then we find that this kind of hematometra, which is actually not really the just blood, but there is a lot of ferritin in this, and DNA changes can occur in the endometrium. And this kind of hematometras, if it is long-standing, more than 8 years, can have severe dysfunction and menorrhagia. So these cases have to be corrected at an early stage. Until and unless it's corrected at an early stage, you can have all these problems, not only the DNA changes and menorrhagia, she can get into severe endometriosis. Endometriosis mostly will disappear once you correct the cryptomenorrhea. You don't have to treat endometriosis, and never go ahead and do a cystectomy when you have an endometriotic cyst with cryptomenorrhea, because we have seen that all these cases of cryptomenorrhea, the endometriosis cyst will disappear without damaging the ovaries. But adenomyosis, we have seen that it persists in cases of cryptomenorrhea, especially long-standing cryptomenorrhea. Even if you correct the cryptomenorrhea, we have seen that adenomyosis persists. That is why I'm telling adenomyosis is completely a different disease compared to endometriosis. And there has been a lot of DNA changes which occur in cases of adenomyosis compared to endometriosis, which are not really reversible. So thank you so much for your patient listening.
Thank you, sir. We were all watching mesmerized, requesting the chairpersons to say a few words.
I hope those videos were good, because I was not very sure about the connection.
No, sir, the videos were good.
Thank you so much, sir, for the wonderful presentation. And especially with all the videos and pictures, it was very learning for all of us. And especially the vaginal dysgenesis repair with the ileum. That was a new thing, and it's very interesting. Yeah. Thank you for everything, and thank you once again for the wonderful presentation. Ma'am Asha Jain.
Thank you, sir. Dr. Rekha, would you like to say something? Nishi ma'am, would you like to say something?
Sir, we were floored with all the presentations. I think all of the people who are watching this, it's a different experience in total. And it's really a privilege to see these surgeries, and that too when you're sharing it in person. Wonderful, sir. Thank you very much.
Thank you.
Thank you so much.
Sir, thank you for giving that time. You know, we lost a bit of the audience when we had that 20-minute break, but people logged back in. So thank you so much for taking that time out and getting everything solved.
Nobody would like to miss the surgeries, ma'am, and especially when we're getting an opportunity to sit at home and watch it. I mean, what else can we expect?
Yeah. So,
Asha ma'am, can I ask one question to Hafeez, sir?
Yes, sir. Yes, please, Dr. Aarti.
Sir, Dr. Aarti here. I just wanted to know what were the challenges faced after this ileal repositioning.
Yeah. See, one thing is all the challenges which you have with an ileal anastomosis. That is one part. That's a gastroenterology part. Now, compared to regarding the gynecology part, you have to be very careful about infections. You need to have a properly prepared bowel before the surgery, and you have to use good antibiotics because otherwise you can get into severe PID. That is one challenge. We have one case, we have got an ovarian abscess actually. So that is one challenge. Now, the second thing is, which is almost there in every patient, is that you can have vaginal discharge whenever the patient takes food. And this vaginal discharge will last for almost 1 to 2 years. So you need to warn the patient that she will have this vaginal discharge and it will last for 1 to 2 years. And she has to bear with it. There is no way by which we can get away with this. We have tried laser vaginal rejuvenation in these patients when I was in Dubai. It works in some patients, but not really. But after 1 to 2 years, you can see that the bowel mucosa will slowly get transformed into vaginal, something like a vaginal mucosa, and this discharge reduces a lot. Another thing is constriction at the level of anastomosis with the vulva. So you need to use a dilator because we have been doing this for very young patients. You know, we get patients at 12 years, 13 years, and all. We do this procedure to prevent the disadvantages of long-term cryptomenorrhea. So in those cases, we regularly ask the patient to regularly use the dilator. For 3 months, we keep the dilator full time, and after that, they can use the dilator in the night. Otherwise, she can have constriction at the area of anastomosis of the vagina to the vulva. Not only that, see, ileum is a little small. Especially in these small children, you find that ileum is little small. We need to dilate that ileum also to get into a proper sexual contact. Now, the results are amazing. That's why we stick on to this procedure, because I have done all the other procedures, peritoneal, amnion, everything I've done, and the results of ileal vaginoplasty are at least 10 times better, especially the sexual contact comfort, because here you have a mucosa. Here you have a mucosa and the length of the vagina is very good. So, and even for the patient also, the sexual comfort is much, much better. And I feel today this is the only method which I will adopt for patients who have the uterus at least. In other patients, fine, you can have usual methods also, but patients who have a functioning uterus, this will be the most ideal method.
Thank you, sir. So what is the preparation? Is it PEGLAC or?
Yeah, bowel preparation, not like before we use a lot of 3 days antibiotic and all, just PEGLAC. You need to have a clean bowel, that's all. You don't have to disinfect the bowel.
Okay. Thank you, sir.
Thank you. Thank you so much, sir. Thank you, respected chairpersons. And I hope everybody has listened carefully, because now we are going forward to the panel. And that panel is of cases which Dr. Suvarna ma'am and Hafeez have already told us everything about. So we are going to just, recap it, because we have half an hour, but luckily I've kept only 4 cases. So yes. Nilesh, would you please share the CVs, please? Aarti, if you would introduce me, I would go ahead. Just do it in short, please.
Yes, ma'am. Yeah, Dr. Asha ma'am doesn't require any introduction, but it's my honor to introduce her. She is the owner of SMSA Hospital, Raipur, Chhattisgarh. She has 34 years of experience. She is the director, SMSA Hospital, medical director, CPRS, elected member, CG Medical Council, zonal chair, Foxy, Food, Drug and MSc Committee, West Zone, Chairman, Mission Pink Health, IMA Raipur, and Executive Member, ISCCP, CG ISAR, and CG SFM. And she has Foxy Recognized Center for Ultrasound Training, Colposcopy Training, and she has training in colposcopy from AV School of Colposcopy, Chennai, Certificate of Competence from Gynec Academy, Gynec Ultrasound, Fetal Medicine and Obs and Gynae, FMS UK Certified, and her fields of interest: saving the uterus, fetal medicine, obstetric and gynec ultrasound, critical care, preventive oncology, and colposcopy. Over to you, ma'am, for carrying over the panel discussion. And
thank you.
I also would like
to call
so much. Yeah. I would like to introduce the experts of the evening.
Yeah, I'll do
Dr.
that.
Shyam.
I'll do that. I'll do
Okay.
that, Aarti. So may I
Okay,
have
ma'am.
the CVs, please?
Yeah. Thank you, ma'am.
Thank you. And I request everyone who's present here, even if you are chairpersons, if you would please join in the discussion, we would be really grateful. So we have Dr. Shailaja R Bidri, who is Professor and HOD Department of Gynae, Sri B.M. Patil Medical College Hospital and Research Center, Vijayapura, Karnataka. She is an EC member of North Zone Kasoga, past honorary secretary Boggs, academic. She's presented many papers, has many publications. She's been a faculty for various regional, state, and international conferences, has many, many awards, and she is also the president of Vijaypur Obstetric Gynec Society. Welcome, ma'am. We are really glad to have you here with us. Our second expert is Shailaja, ma'am.
Thank you. Thank you very much for your kind words for introduction. Can you hear me?
Yes, ma'am. So, ma'am, now we proceed to the panel. Dr. Shyampyari Jaiswar, ma'am, is the president of Lucknow Society, who had agreed to be an expert, but she's just gone for another webinar. We have Dr. Dinesh Pathak, sir, a dear friend, who's the president of Firozpur Society. Welcome, sir, for being here from the very beginning. We have Dr. Madhu Goyal, who is the secretary of Kotkapura Obstetric Gynec Society. We have Dr. Sujatha Anbalagan, who's the secretary of Krishnagiri Society. Madam has also been with us from the beginning. We have Dr. Nidhi Johri, who's the secretary of Lucknow Society. Dr. Sheetal Nath Kole, who's the secretary of Ichhal Karanji Obstetric Gynec Society. And Dr. Preeti Niranjan, ma'am, who is the past president of Baroda Obstetric Society and Menopause Society, Baroda. Very graciously, she has agreed to be here on this panel. So I request all of you to join in the discussion. It will be just a recap of what we have done. Before everybody finishes, I would like to request you to please nominate me from your societies for Food, Drug and Medical Surgical Equipment Committee. Please do that. I have already sent you the details. I'll not take much time. Now, this is case one. I have not actually enumerated what we did. It's up to you to discuss what happened. I did an awareness program in a women's polytechnic college. It was an adolescent health program. And at the end of the program, a tall, dark, young girl came and she was standing next to me. She said, I want some private time. I said, what happened? So then she's telling me that she's never had any menstruation. Never. She had small breasts. Her BMI was 22. There was no axillary or pubic hair. And her genitalia were female external genitalia. She was of an average height, 5 feet 3 inches. So what will you do? Any panelist can answer. I haven't allotted. Yes, ma'am.
I will like to answer this question. First of
Yes,
all,
ma'am.
very important thing that she's already 22 years old. Means it is a strong possibility that she had been seen or taken by her parents to some or other gynecologist. So first we should ask that whether she has got any
Ma'am,
investigation.
she's never been anywhere.
Oh, that's very surprising. And first is that as she has got a small breast, her BMI is 22. She doesn't have any axillary and pubic hair. That means she is deficient in estrogen also and androgen also. So first of all, we will get her sonography done and we will get her blood test done, especially FSH, LH, prolactin, and total testosterone and thyroid. That is sufficient for it. And whatever picture comes to us, we can guide her further. If she agrees, we can do her the local examination for the development of local private parts. As she has, there is no pubic hair, no her no axillary pubic hair, but her external genitalia are normal. And that will give us the guidance what should be done next.
Okay.
Yeah, ma'am.
So,
Yeah.
yes, sir.
Yeah, yeah. Because there is the absence of axillary and pubic hair. That means they see insensitive to the androgen hormones. So we have to think in that line, first of all. And as a case of primary amenorrhea. So for that we will know to, first of all, we perform the thyroid, as ma'am already said, that FSH level is a must. So we can know whether the level is low or high or normal. If it's more than 20 intestinal unit MIU per ml, then it's we have to screen with it's ovarian failure or premature ovarian failure. But if it's less than 20, then we would think whether there any other cause also, whether they or not, like a prolactinoma or other any other tumor. So we can go for that brain MRI. We can go for that, and if we find that okay, she is not a hypogonadism is not there, you can rule out for the FSS level. And if it's more than 20, then we can also go for karyotyping as is insensitivity. So we can think of the testicular, we examine her locally to see whether there any palpable mass in her the genital area like labia majora or minor, labia major inguinal canal region. So if they is present, then we can more think of like testicular feminine syndrome or like that. So it can be ruled out by doing karyotyping.
Can I take that?
Yes, please.
Ma'am, I just wanted to emphasize on the very point that since we are seeing that there is no axillary and pubic hair as well, and of course, we will start doing the FSH levels and the rest of the hormonal levels. But at the same time, we should keep in mind that we have to do the karyotyping of the patient as also, which is also very important, which will give us an insight because she has no, at 22 years of age, a young girl who has a very small breast and no hairs. So the karyotyping will also found a major place in the investigative tool.
Okay. Does somebody want to add something to it?
And if the FSH, basically everything rests with the FSH levels, and the FSH levels being normal, then we have to do the rest of the thing, like we can do the base growth, and if it is delayed, then constitutional delay of the puberty, then the rest of the things. But if it is more than 20 ml, what sir has said, then we must do the karyotyping and then decide which way to go.
Okay, so now the patient is in front of you, right? She's come to your OPD. What is the first test that you want to do?
Physical examination.
You examined her and you have, yes.
Ma'am, we would like to take a very, very detailed history for the first. Because she has come for the first time, as you have already told, she's a 22-year girl, and we have to count. First of all, we have to take great history and then counsel the patient, and then later on the examination part will come, and then the investigative part.
Okay. Dr. Sujatha, are you there?
Yes, ma'am.
Yeah, ma'am. Would you like to add something before I take this to the expert?
Yeah, no, ma'am. Actually, as everybody have told, we're going through the history and examination. We've all known that some amount of estrogenic exposure was there. That's why the breast development is there. So the next thing would be to go for the FSH level estimation. So going with the FSH level test and then analyzing the values and then deciding the karyotype, that would be the best. This has been already told by all the panelists, so that is the way I think it has to be progressed.
Okay. Shailaja ma'am, you're there? Please put on your video, ma'am.
And physical examination.
Ma'am, I would like you to actually sum up here what would be the first thing you do in the OPD and what test you would advise.
And already you are told about the pubic hairs are not there and breast development is underdeveloped. All these things you already mentioned. And in these conditions, we have to go for what madam has told, karyotyping, and also ultrasonography, whether uterus is atrophic or any ovaries are there or no. All these things we have to get it done. simple investigations first. Then we have to go for a evaluation genetically and hormone level.
Okay. So actually, I have an ultrasound in my OPD. So we did a scan. And we had no uterus. And we had streak-like appearing ovaries. Streak ovaries with no uterus. So now what is your plan of action? What are you going to do?
As there are streak ovaries and she has got a very less amount of estrogen, we should think of a long-term consequences for the bone health also and other health parameters. And second, breast development. So we can very well help her, like giving her the estrogen. In this case, there is no need to give progesterone because there is no uterus inside the body. That is one thing. Good counseling by calling the parents with her, because sometimes it happens they get married to the girl and then another issue comes. So I make it a point that I call the parents, I tell them, don't spend money on the marriage. If you want to get married this girl, your daughter, then you can very well marry to the person who has already got the child, and you should tell all the details to that. I feel that this is also a very important issue which should be taken care by us as a social counseling.
Yeah,
Do you want to do? Yes, sir.
Yes. As the absent of uterus, so many times these patients come late to us, and so we counsel them as they are being reared as grown up as a consider them as a female child. So the other way they are more socially acceptable to make whenever they want to get married, or often they are married. So by counseling that whenever you want to get married or we have before marriage, we can go for vaginoplasty. So considering that
she had a vagina, sir. It was a blind pouch. She had a vagina. She didn't have a uterus.
Down syndrome.
Ma'am, in this case, I think only counseling and so, which is very rightly said by sir, social counseling is very important in such patients because we can't do much and we have to tell the patient as well as the parents what to expect. Because she has very streak-like ovaries, so we will always see that she will have very less of estrogens and the whatever the investigative part we are doing, which will not be helping her much regarding the other reproductive parts. So that is
so
very important.
Does anyone want to go ahead and do her karyotyping and alpha reductase and everything? Do you want to do it?
Only karyotyping.
Karyotyping must, ma'am.
Karyotyping is a must.
Okay. May I know why?
Yeah, because if they get so androgen insensitivity is there, then there might be possibility that the male gonads are there. So we have to remove it because there might be chance of gonadoblastoma.
Malignancy.
Malignancy.
Yes.
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 If it's a complete androgen insensitivity, then it has to be removed as soon as possible. If an incomplete like testicular feminization, then after attaining puberty, it should be removed. 18-20 years like.
Yes.
So in this case, I would like one person to sum up before I take to the second case.
I will like to sum up.
Yes, ma'am.
Simple examination in the OPD and thinking in a right way may help not only the patient but also prevent the person from spending a lot of money on the investigations and going haywire. So what we did the first local examination and we had a sonography machine. So we did the sonography. And next part was the karyotyping and counseling to the parents and patient also.
Okay. So thank you, ma'am. Thank you, Preeti ma'am, for that. Now we proceed with case 2. This is a 15-year-old who was brought by her parents. She is extremely short, but she doesn't have that dwarfism-like figure. No? It's a normal figure. She is very, very underweight, BMI of 14, no secondary sexual characters, but her intelligence was normal. And external genitalia appeared female but infantile. So now, what do you think this is? Seeing this history, this patient, what do you think this is?
And BMI is very less, 14. So, an external
She was hardly less 4 feet.
Yeah, all the characteristics suggest of more like of androgen insensitivity and more because of the hypothalamic involvement is there. For 15-year-old girl, BMI 14, no sexual underweight. So we have to think in that way. Somewhere the pathology must be lying in the hypothalamus. So we have to rule out the hypothalamic or central compartment for pathology if there is any. So first of all, we like to go for the FHS level as we have already discussed earlier. And if it is less, then you have to think of the hypochondropic hypochondrism in that way. And we have to give her adequate nutrition so that now we have to take the proper clinical history, whether there is any stress factors there, whether she's having her diet, regular diet or not, she's drinks her normal exercise or not. If you're underweight, that means there's some sort of stress, or some there is external factor or internal factor which is causing the hypothalamus to release less hormone. Okay, so
but her intelligence was normal.
Yeah, intelligence was normal because the genetic system must be normal. Intelligence is not affected in these cases.
I will prefer only two things. First is the sonography, and second, her detailed diet history. Any history of tuberculosis. If the uterus is present, both the ovaries are present, they are in normal size and shape according to the age. Nutritional history is very, very important. And any history of tuberculosis related to the tuberculosis, we can very well rule out.
Okay.
Ma'am.
Okay, Dr. Nidhi. Yes.
Yeah, ma'am. If I see such a patient, the most important thing, as earlier also, which has been told by ma'am also, that I would like to take a very detailed history. And the history basically should also come to point with the tubercular part of it and the nutrition, which is very important, since everything is very proportionate. And the girl is already 15 years old. The intelligence is normal. So then when we have taken the history, we will do the local examination. The first in such patients, I would like to ultrasonography and FSH values. Just two investigations. One is the ultrasound scanning, which we already have in our hospitals, and the simple FSH levels. So ultrasound scan will give us a lot of information. And the history itself will give us rule out the nutrition part, the tubercular part. And then later, if by deleting all these factors, we can then further add to the investigative parts. That would be my approach.
I will like to add one thing. I will ask her mother when she got her menses. Sometimes it is
Yeah, ma'am, whatever you are saying is correct. But since the girl has a very low BMI, the parents' stature, the parents' appearance, and when they have entered your hospital, that is also very important, because there are
parents
many
are absolutely normal, ma'am. Parents are absolutely normal.
Yeah, because many signs, ma'am, you all are the gems. You all know that at times parents are short and they will just ask, madam, hamara bachcha itna chota kyun reh gaya? And when we counsel them, then they are able to understand. So I think I still stand that point that we take detailed history, do the local examination, and the first and the foremost would be a simple ultrasound scan, and do FSH levels to rule out the first part, that is the hypothalamic pituitary part, where the problem might be lying, and then later on we can delete one by one.
Okay, so her investigations were done. She was sent to a pediatric endocrinologist as well. She had an infantile uterus, okay, and her FSH levels were about 2. FSH LH very, very low. We also got a growth hormone levels done, which were extremely low. So everything low. Now what are you going to do with this patient?
Best to be treated by endocrinologist, pediatric endocrinologist, right? Person should treat her.
Yes,
but
I
also agree that we send her to a pediatric endocrinologist, because now the growth hormone is also low, so they will have to scale it up. What is to be done, because that means that the pan hormonal levels which are coming down are less. So it's basically to be referred to a pediatric endocrinologist.
Do you think there is any role of a bone X-ray of her joints, of her, wrist or anywhere? She's about 4 feet. No? So do you want to see whether she has growth potential, how much is left, how much is going to be with medicine, how much she's going to gain? Would you like to know that? Because these are questions parents are asking you.
Yeah, ma'am, I would like to do what you are asking is a very correct question, which we should. But when we have already discussed about, we've seen that the growth hormone is also very low. And when we are getting preparing the patient to administer the hormones, whatever we want to, then we would like to see the x-rays of the joints to gauge that then we will be able to predict and counsel the patients that if we give this much of treatment or we administer the hormones, how much is the chance for improvement in the girl's stature. That would be a predictive value. That will.
Madam, hello.
Yes, Shailaja ma'am.
I would like to add juvenile diabetes also. We have to many times nutritional and low build. Juvenile diabetes. Patient is young, 15 years old.
Yes. Yes, ma'am. Ma'am, your video went off and we can't hear you. Shailaja ma'am? Yeah.
Madam, I would like to add one more thing here. You have to rule out the juvenile diabetes because malnutrition and low build and intelligence is normal. So we want to rule out juvenile diabetes as one of the investigations in this case. I want to add.
Yes. Thank you, ma'am. Thank you. Anybody else wants to add anything? Dr. Sujatha, would you like to add something here?
Discussed, ma'am. My panelists were all clear, so no points to be added.
Ma'am, I would just like to ask one question that if all the growth hormones, the FSH, LH, whatever you are telling, all the hormones are very low, is there still a possibility that the patient might be having juvenile diabetes?
Yeah, that is what Dr. Shailaja just said, that we need to test her for juvenile diabetes. So she was tested. She didn't turn out juvenile diabetes, but then she received injections of growth hormone. I sent her to a pediatric endocrinologist and then we lost her to follow up. But what I know was that she put on some height and she was given growth hormone injections. That's all I know about this case. So this has been already told. So if it comes to the hypothalamic, eating disorder, functional, gonadotrophic deficiency, infection, malabsorption, tumor, that's it. So now, do you want to test her for anything else?
Madam, once we had already referred her to the endocrinologist, he is the right person.
Will you do a karyotype, ma'am? Before you refer, would you like to do a karyotype?
Yes.
Okay. A karyotype, a thyroid test. Do you want to do an MRI of her head or sella and a pelvis?
Yeah, no.
I would not. I will not do. I will not do.
Okay. Ultrasound we've already done. So this is the chart that madam had already said. So low FSH-LH, functional amenorrhea, constitutional delay or primary gonadotrophic releasing hormone deficiency. This is what she had. Are we already at case 4? I missed out case 3.
So next, madam, next. Case 3. Scroll down.
So we take 4 first. This is a 26-year-old. She has been married for 3 months. Now her mother-in-law and husband have brought her to confirm pregnancy. That since she got married, she has not had her period. Pregnancy test is negative. On asking privately, she had never had menstruation. Her mother died when she was small and she had some discharge per vaginum, which she thought is menstruation. Father and brothers married her off. No one asked about menstruation. Now what are you going to do? So in this case, there are multiple factors.
I will like to answer this question because few days before I had the same similar type of patient. So it is better that instead of disclosing everything to the in-laws, best policy is that get the sonography done first, which is available with us. That is one. Presence of the vagina, they got a normal intercourse. That's why they suspected of the pregnancy. This is one. Then we can ask her to call the father and brother. And best is that they should be counseled in a very clear way. Either if the absence of the uterus or if the uterus is present and she is already 26, then chances of having the very infantile uterus. We have to see whether she has got a good secondary sexual characters are present or not, like the good developed breast, height, weight, and pubic hair. And later on,
all that was there. All that was there.
And then now it comes the question of decision of the family also. We can very well guide
Very
you what the
scanty
ways.
hair, but she had hair. And she was a little short, but her husband was also short. So you don't really pay that much of attention.
So, ma'am, can you tell us about what was the findings on the ultrasound?
She had a very small uterus, very small. It was like about 25 cc volume uterus with almost unidentifiable ovaries, very small ovaries. Her FSH LH turned out extremely high, and she had almost undetectable AMH and inhibin. Now what?
I will like to add one thing. This patient may turn up in some medical legal issues like a divorce. So it is better that we should get the sonography done from outside radiologist, 3D sonography. So we will have the good evidence. This is one thing. We can very well refer her to the endocrinology. So multiple people who are involved in giving the opinion.
Okay, so your idea here is keep yourself safe.
Yes.
Yes, ma'am.
So that we are not dragged into court multiple times.
Yeah.
See, we are all experts here. May I ask a question which is not related to this topic, but I need just some advice. One couple and the wife is asking for divorce that her husband is impotent. On that ground that he is impotent. Now, the husband says, I can get a checkup done and show that there's nothing wrong with me. So is it necessary to have a private doctor or a government doctor, or anyone can work?
Government doctor.
Government doctor.
Why government doctor? Means that is what they asked me, so I'm asking you, why government doctor?
Reason is very social because everyone has got the feeling that private doctors may favor some or other partner. So it is best that the responsibility should be shouldered on someone else, and they are the right person to give the opinion.
Okay. So I told him to go to an andrologist in a government setup. So he said not available. Then I said go to a surgeon, but you have to go to a government setup. The basic reason is, as per Supreme Court guidelines, if we give anything in writing, private doctor has to go and stand in court, spend so many days. But if a government doctor gives it, anyone else on that chair can answer, just looking at that report. So I think medical legal, that is it. So now case 4, if somebody would sum it up, what are you going to do?
First thing is that,
yeah, as you have already said, madam, the level of FSL is very high. So I think again it comes to an ovarian failure, case of ovarian failure or insensitive ovary. So premature ovarian failure might be one of the cause, because there might be autoimmune disease. So we'd like to go for thyroid disease, because there are many autoimmune diseases like commonly associated with thyroid, hypothyroidism. So that can one way it can guide us whether it is there or not. And polyglandular disease is also there. So we have to sum up all these things, whether she is suffering from only the ovarian failure, ovarian resistance syndrome, or is it the polyglandular disease. So we can go for calcium, serum calcium, phosphorus, thyroid, TSS, and T4, and also the testosterone level,
Calcitonin, parathormone.
Parathormone, and also the androgen hormones also there. The adrenal gland hormone like the 17 beta hydroxy CH or progesterone hormone also we should test for them. And 21
Thank you, sir.
Yeah.
Thank you, sir. So now we come to the last case. This is a 16-year-old, 170 centimeters in height, but her BMI is 40. She is 114 kilograms. She has primary amenorrhea and has been brought by her mother. She is a class 10 student. Secondary sexual characters are developed. There is no hirsutism. What do you suspect in this patient? What are the investigations and what is the management?
We will suspect PCO, that is one thing. We should get the sonography done first thing, and that will give us a very clear idea about the presence of the uterus, presence of the ovary, and characteristic of the ovary. That is the first thing which should be done.
Dr. Nidhi?
She has left.
Nidhi is there?
She has left. She has got emergency, so she left. And now
Okay.
Dinesh can answer.
Yes, ma'am. As I see, very overweight. BMI is 40, at the 60 and 170. So as we can see, the BMI is 40. So we can think of some eating disorders also. We should consider whether there is any binge eating or not. So which can stressful conditions. So hypothalamic again comes to play a very role in this such cases. So you have to rule out again the stress factor here. Why she is overweight? Whether there is any tumor which is causing her to eat more and more, or the genetic disease which is causing her to eat more and more. Sometimes, like the Prader-Willi syndrome, we know that the patient cannot resist themselves from eating, so they keep on eating. Binge eating is there, and whether second thing is diabetes mellitus. Also, we have to check for diabetes mellitus also here, where she overweight because of that or not. Because second sexual is already well developed, so I think she's not androgen sensitivity is there, so we can go for check the FCC level whether the FCC level is normal or not, and if it's normal, then we have to look for the uterus and ovaries at the same time, and if they're okay, then we can go for position withdrawal test. After asking her, first of all, we have to ask her to lose her weight. We have to 1640 is too much, and if to find out the cause, what is causing her to have so much overweight. If lose her weight,
sir, one more thing I want to ask. Polycystic ovaries are not diagnosed by ultrasound at the age of 16 years. Right? So,
ma'am, not polycystic ovary, but the symptoms similar to polycystic ovarian disease, like the adrenal gland hormone, the hormone deficiency like 17 alpha enzyme and 21 alpha hydroxylase.
Yeah, so all that is different. We need to do the hormonal panel rather than an ultrasound for ovarian morphology. That is the point I wanted to bring out. Shailaja, would you like to say something on that?
To make it confirm that the ovaries are present there. That's one.
Ovaries are present and uterus is present.
That is true. You have seen the presence of uterus and ovaries.
Yes.
But Shailaja ma'am, would you like to add something here?
FHS and LH levels, weather variation.
And thyroid.
Hypothyroid also. You have to
HbA1c.
Correct.
HbA1c, prolactin, serum-free testosterone. Okay, these are the tests that we are going to do on her because an ultrasound morphology of polycystic ovarian disease doesn't say anything. So this girl was in class 10 and her mother was that my daughter eats nothing. She is so fat, but she doesn't eat anything. And you know what she was eating? Only 4 family packs of Uncle Chips a day.
There's junk food they want to eat, and
that was the only thing she was having. Because
girls,
I'm studying, so she is eating like that, studying and eating.
That is because of stress also, madam. They'll eat whatever they like and junk foods. That is there. And in front of parents, they won't eat that type of food what they give. And they
No, their mother was providing her, ma'am. 10th का exam है, पढ़ रही है. So this is basically functional problem. So what do we have to do? We have to make her weight normal.
First we
Somehow.
have to ask her 10th has completed or not. That is first
No.
important. Only
No, not completed.
Then they will not follow our advice.
So what do you suggest now? She has been brought by her mother, right?
You have to advise mother to give her what proper diet is there, and she has to do some work, routine work, as well as exercises. That will help a lot. And we have to make her mood elevated for walking and other exercises. Otherwise, they won't. Because we have to explain regarding what are the consequences of obesity and other things we have to explain in future. Then they may agree for girls may agree for walking and other exercises. That will help in reducing the weight.
So basically, it is the kids who have to agree. And these days, the parents are not in a position to ask children to do anything. You know, they're requesting. That's it. So
the diet can be provided by the family or mother, no? Proper diet.
Yes. Yes.
So she has to cook right.
That is true. So she needs a proper diet, she needs to reduce weight, and then we need to evaluate her because it could be just constitutional delay and impending polycystic ovarian disease. So anyone wants to add anything before I just read this out?
Counseling plays a major role in this. So she needs both the parents and the patient requires counseling.
And I think that not only counseling, but she needs a good support system from family members.
And I'd like to add hypothyroidism also we have to rule out in this case.
Yes. So again, diabetes, type 2 diabetes, metabolic syndrome, hypothyroidism. And she's just 16 and having a BMI of 40. So what that is doing to her bones, which are not yet mature. So now, before I end the panel, I would like to have some take-home points from all the people present here. I start with you, Shailaja ma'am, and then we proceed.
It is a really very good session, madam. And we have to take home that all the investigations, whatever required there for a particular patient, we have to get it, and not all. And one by one, we have to vote for the primary amenorrhea, what are the causes for that, and how to manage.
Preeti ma'am?
I would like to say one very, very good thing. These are the patients, they should not leave us. We should make it a point that if we should reach to the conclusion, we should tell them the long-term consequences and we should give them a long-term management also. And that needs, sometimes I feel that we should charge them once or twice and later on they should come repeatedly to us. And we should tell them very clearly that you may need to come number of times, you may need to get the number of investigations. But at the end of the session, we will give you the good diagnosis, what is the right thing, and we will guide you for the rest of the time. That should be the message from our side.
Okay. Dinesh, sir?
Yeah, the patient and the family, they are already come with a lot of stress in such cases. So first of all, we have to deal them very gently and very in a familiar manner. So they are very comfortable and they discuss everything, they give us everything. So whatever we ask them to do or perform or investigate, they do it ritually and they follow our advice ritually. And we have to keep the confidentiality and we have to boost up the image of the girl, child, especially young girl child who are coming with the anemia cases because they are being bullied like anything. So we have to boost up her morale also and counsel the family member also. So that they also give positive feedback to the children. So they are not being bullied, and if they are bullied, they are to get rid of it properly and not have any without any negative impact. Thank you.
Thank you, sir. Thank you. Dr. Aarti, would you like to add something here?
Ma'am, it was an excellent session and excellent panel discussion, and the surgeries by Dr. Hafeez sir was very good. Rare cases, and loved the way everything went on time. And thank you for giving me this opportunity, ma'am.
Oh, I wanted a take-home point from you, dear.
Oh, sorry. Sorry, ma'am. So, ma'am, I think most of it has been covered, and nothing much, ma'am.
Okay, so I would like to add one thing, which actually Preeti ma'am has said, but we have not said it in the end, and that is always make yourself safe and think about the medical legal aspect for the patient also. If she is married, if she's in a relationship, if she's in a family with not much support, we have to think of the medical legal consequences of such a diagnosis before we rashly just say what is wrong. And it is very correct that not everyone may be able to afford all the tests, so we need to get it out which ones we are going to get done and which one is needed after the patient has been thoroughly examined and a detailed history. So I think, thank you. Shailaja ma'am, we would love to see you, Your camera keeps going off over and over again.
I'm only putting off.
Ma'am, I'll be just ending the session now. So I request all of you, please nominate me from your societies.
Okay, madam, okay, all the best.
Thank you, ma'am. I thank all of you. I thank our chief guests, guests of honor, chairpersons, speakers, our experts, and our panelists. Also, all the viewers who have listened in, and Corona Remedies, our educational partners, for being here with us and giving us all support. Thank you. Thank you very much. See you next week again.
All the best.
Thank you. Thank you, sir. So next week we are going to do early IUGR. Next Wednesday is going to be early IUGR. So viewers, you may just subscribe and be ready for the coming feast next week, 5 o'clock, same time. Bye-bye. Good night. Namaskar.
Thank you. Thank you.
Thank you, madam.